Thank you, Nikos, for that great illustration of the escape points, which I think actually ties in well with a portion of my talk. The focus here with relation to pelvic vein disorders is to illustrate the importance of management of vein obstruction. And I think we're hearing more and more of the importance of this over the years. And again, the focus today is for my talk in the next 10 minutes is to illustrate that. I'll show you some case examples and then maybe some recent data to help support this. Some of this you've already seen now. The interconnected venous systems are quite obvious now within this. Pelvic venous insufficiency is not related to just veins alone. That's been nicely illustrated by the previous speakers in this session. The uterine venous plexus, if you will, is supplied by the renal vein or has intimate relationship with the renal vein and the iliac veins. And in fact, pelvic venous insufficiency, which I think is a good terminology to use, has 4 distinct clinical presentations based on this, in fact, interconnected venous systems, right? So primary pelvic venous disorders, the new terminology that Neil had suggested, can present with 4 distinct clinical presentations: chronic pelvic pain, pelvic varices, and renal and leg symptoms, depending on the escape points in which are implicated on that patient's unique anatomy. So I think it's important, again, to emphasize the anatomy and a review of the imaging that's available to you, whether it be cross-sectional or with ultrasound imaging. The pathophysiology is quite clear. I think we think of this as other venous problems. There's issues with insufficiency, and the incompetence then results in varices within respective tributaries that then result in pain. That etiology of the incompetence can be primary or secondary. This is well established within the lower extremity venous insufficiency understanding. And the causes of secondary incompetence in this particular pathology can be unique, partly due to the female gender, but also because of upstream compression. And the most common upstream compressions are, just as we mentioned, implicated by the left renal vein or the iliac vein compression. And I think if you say in this patient who had no specific compression but has specifically large dilated ovarian vein on the left and large pelvic varices, this may be just strictly related to reflux component. As has already been shown by a number of the other speakers, the reflux and obstructive component is important. But I mention this because if you understand the venous reservoirs, and again, this was also shown, the renal hilar plexus and the pelvic venous plexus will help determine which of these is implicated within the patient's symptoms. For example, if you have a patient with flank pain, or if you have a patient with pelvic pain, it's not always the same reason for why they have that. We have to understand, is there an obstructive component? Is there a reflux component? Is it combined? Is it compensated or not compensated? So let's get into that just a little bit more. We just define the different reservoirs within the patients that we're addressing here. And so the symptoms are related to the reservoir that's in play or has distension. We know that the engorgement of these veins can cause stretch and stasis, and the ovarian and pelvic veins then can activate pain receptors within the venous wall. But those dilated veins as well can cause associated local inflammation and then can also affect nearby nerves and veins, and this is the so-called visceral pain of pelvic venous insufficiency. And we've also established that there's a reflux and obstructive component. And we've, as Kush nicely walked through, these patients can have either uncompensated or compensated obstruction, right? So if there's an obstructive component and there is no outflow, then symptoms are going to be related to that specific reservoir. If it is compensated and there's now outflow through a collateral so-called pathway, let's say, then the symptomatology is going to be related to that collateral outflow. And so we'll show that with some examples, I think, case examples to illustrate this nicely. Here's a 31-year-old female who's got symptomatic pelvic varices, including pelvic heaviness and pain limiting her day-to-day. And what you'll see here is that she has what would be a left renal vein compression, at least on imaging, a dilated left gonadal vein. There's perhaps some compression of the iliac vein as well. So she has either reflux or obstruction, or is the obstruction causing the reflux? And so a careful look at this would not just take you to say, let's go straight to ovarian vein embolization. Perhaps I think maybe there might be a different strategy or perhaps a combination. And I'll show you some data later to suggest this. Here's a different patient with 35-year-old pelvic pain with right lower extremity venous claudication. And what you'll see here is she's got, again, a dilated right ovarian vein, not left, but right. And the further history that I haven't shared with you is that she's got a chronic history of a known right iliac DVT, which is now, when I meet her, presents with now gone on to occlusion of that right iliac vein system, and she's gone on to compensate this obstruction with these dilated varices, pelvic varices, escape routes, if you will, and then up the right ovarian vein. And in fact, you see that on venography at the time of revascularization. And you can see these large pelvic veins cross-filling into the left iliac system, and again on IVUS as well, it's quite clear that this patient has what we've demonstrated to be an iliac vein compression that has now been compensated, and it's likely the cause of her symptoms, the dilated pelvic veins. In the same patient, illustrated points here is the right ovarian vein and the pelvic varices. But then upon revascularization, you can see we've stented her now, and she in fact has a widely patent iliac vein system. And on venography, we no longer see those pelvic varices filling. But the proof is that, two, symptomatology-wise, is significantly improved. She no longer has the pelvic vein symptoms. And we see on follow-up, the same patient, following stenting, you can see the decrease from stenting to non-stenting of the varices that are present. And there was no embolization of the right ovarian vein done in this patient. So an isolated iliac vein compression, resolved recanalization, no treatment or embolization strategy in this patient, but resolution of her symptoms and, in fact, improvement on imaging, but more importantly, symptomatology in this patient with regards to her pelvic veins. Here's a different patient. Who was treated with a right iliac vein recanalization outside hospital, presented with worsening symptoms. And you can see the stent is now occluded, and a right lower extremity venogram shows prompt filling of the periuterine veins that then decompress through bilateral ovarian veins here. So you can easily, nicely illustrate, and perhaps an extreme example, the symptomatology is not because of reflux per se primarily, but because of a obstructed iliac vein. In this case, a previously recanalized stent that's no longer open, and now we've compensated this through the ovarian veins, and the symptoms are persistent. Once we revascularize this, in this case with angioplasty and stent, improve flow. Here's a different patient with an occluded IVC, iliocaval obstruction. You can see here the cava is occluded. There's a large left ovarian vein, and then obviously the pelvic varices owing to the ovarian dilatation. In this patient who had post-iliocaval reconstruction, you can see now the stent and the dilated ovarian vein. Nothing has been done to the, dilated IVC, nominal caliber, and now the ovarian vein, no embolization has been performed. However, you see now reduction in overall size of that, and in fact, resolution of the pelvic varices. When we talk about pelvic venous insufficiency, we've already discussed, Neil did nicely, that the review of the data is lacking. While the outcomes are decent with primary embolization, utilizing a strategy of ovarian and/or internal iliac embolization, many of them show good results, but they're lacking in quality. They're retrospective case review studies or small numbers overall. And in fact, if you look more closely at this data, many of these patients actually in some series don't do quite well. In some, upwards to 40 or 50% did not improve, or in some cases got worse. And if I show you that previous, if you recall the previous case with the iliac vein stent occlusion, and now with pelvic varices and ovarian vein dilatation, you can imagine a strategy of embolization in that setting, while it sounds silly, would only make those patients' symptoms worse. So I presented this as an abstract last year, but it actually went on to publication. This is Dr. Pappas' group, who's I'm sure here in the audience. But I want to illustrate this because the publication is worth reviewing, and I think it illustrates nicely the importance of evaluation of iliac vein obstruction. This is a retrospective chart review from their institution, 220 women, 227 procedures during this period of time in which pain scores, SEEP classification, and duplex ultrasound evaluation were done. All patients had diagnostic venography consisting of pelvic and left ovarian veins, as well as their iliac veins. Patients were treated with either a combination strategy of ovarian vein embolization or iliac stenting, sometimes in the same setting or sometimes in a staged setting. And 82% of their patients demonstrated iliac vein stenosis as they defined by greater than 50% reduction on intravascular ultrasound. Patients responded best as far as symptomatology, dyspareunia, and fullness to ovarian vein embolization with stenting, and worst with ovarian vein embolization alone. So the combination strategy was better than alone. What they further tried to assess was the role of stenting for alleviation of pain in patients with reflux and occlusive disease, and analyzed ovarian vein embolization stage versus simultaneous group. They wanted to tease out, is the embolization more important, or is the stenting or resolution of the obstruction more important? So in the staged groups, only 9 of their 88 patients that had the staged procedure, embolization and stenting, reported a decrease in their pain score with the embolization alone. After stenting, though, there was a significant decrease in their pain score, as reported in their cohort. And after the planned stage stenting, you can see the VAS scores decrease significantly. Concurrently, when they had the simultaneous group, they showed the same or similar reduction from initial pre-pain score to post-pain score. And so this owed significant, I think, point towards the incidence of iliac vein outflow obstruction and pelvic venous insufficiency was greater than previously reported in their cohort, and that treatment of the iliac vein outflow obstruction was more important perhaps than ovarian vein embolization. And that may account for the cohort of patients in some of those analyses that had either no improvement or even worsening of symptoms following embolization alone strategy. So the take-home point here, pelvic venous insufficiency is a common cause. There are 4 clinical manifestations. Obviously, ovarian and internal iliac veins are implicated, but we can't focus just on the reflux. There's clearly an important obstructive component. And in the right clinical setting, you confirm the reflux, but look for that central outflow obstruction, and that endovascular treatments in general I think are very effective, but doing which one first in combination, or perhaps focus on the revascularization of the compression may be the strategy in many patients. Thank you.